could always count on my dad to help me make the right choice, from the right eyeglasses to the right college. So after he suffered a stroke, I knew it was my turn to help him make the right choice in rehabilitation. I asked his doctor who she trusted for the best care and outcome, and she said, Encompass Health, the nation's largest system of rehabilitation hospitals and the name more medical professionals refer to. My dad has always wanted what's best for me, so I did what's best for him. Encompass Health.
We would like to thank Encompass Health for being our premier sponsor for the 2022 BIARI Conference Series. We would also like to acknowledge our presenting sponsor, Marasco and Nesselbush. We're happy to be supported by our presenting sponsor and the team of attorneys at Marasco and Nesselbush. For more than 20 years, they have provided trusted legal care for clients who have sustained brain injuries as a result of an accident, such as a motor vehicle crash. The Marasco and Nesselbush team knows all too well the devastating impact that a traumatic brain injury can have on the injured person and their family. The firm has handled hundreds of cases involving brain injuries and has resources and experience to ensure that their clients recover as best they can and are also fully compensated for their injuries. We would also like to acknowledge the Department of Health and Human Services, whose funding helps BIARI provide programs and resources to the brain injury community in Rhode Island. Supporting friends of BIARI include Neighborhood Health Plan, Robin Hill Farm, OSL, Neurorestorative, Speechworks Rhode Island, Just Ask Aphasia Group, Avatar, and the Roman Catholic Diocese of Providence. Good afternoon, and welcome to the second session of the Brain Injury Association's 21st Annual Conference. My name is Doreen Grasso, and I'm the Education and Program Manager here at BIARI. We're delighted that you can join us today for Fair Play, the Impact of Health Inequities on Children with Traumatic Brain Injury by Ellen Mitchell. Before we get started, we have just a couple of housekeeping things to talk about. All participants have been emailed an evaluation form. Your feedback is very important to us, and it's also your ticket to CEUs if you're applying for them. Please fully complete the evaluation on both sides, answering all questions and entering your name on the top, please. And email it to richard@biari.org. That's richard@biari.org, so we can easily process your CEU. It'll probably take approximately a week or within a week. Lastly, please type any comments and questions into the chat room area. We reserve time at the end for Q&A at the end of the presentations where we can have some Q&A with Ellen. I'd like to introduce today's speaker about Fair Play, the Impact of Health Inequities on Children with Traumatic Brain Injury, Ellen Mitchell. Ellen Mitchell is the Director of Industry Relations for the Commission for Case Manager Certification. She has over 25 years of experience in the field of hospital case management and has presented nationally on topics of interest to the specialty. She holds a master's degree in acute care nursing. She is certified in case management by the Commission for Case Manager Certification. Welcome, Ms. Mitchell.
It's a pleasure to be here. Thank you, Doreen. Excuse me, you know, it's allergy season, so you're gonna have to bear with me, okay? I'll try not to choke to death while I speak. I'm actually really happy to be back again. We were part of the program last year, and I'm really happy to be part of this again today. But I have good news and bad news from what I can see on our little Zoom call. The good news is that we're a really small group. So if you have questions, please put them out there. We'll probably have plenty of time for conversation. The bad news is we're a small group, so tell your friends. Maybe they can access the post-party fun, okay? And I'll leave that to Doreen to explain that later. Right now I'm going to share my screen so we can look at the slides. Here we go. Let's see what we have going on here. It's so much fun to do this here on the fly. Here we go. Oh, look at that lovely picture. Isn't she cute? Okay. Let's talk about the learning outcomes, okay? They're here on the slide for your review, but primarily we have 3 goals today, and they're pretty big goals for an hour, but we'll do our best. Describing the incidents and types of brain injuries that are experienced in this pediatric population. We're also going to look at the social determinants and the inequities that impact the outcomes for these kids. And we're going to try to develop strategies that you can access resources and create a viable case management plan. All right. So a little background, okay, as an introduction. Young children actually have one of the highest rates of TBI emergency department visits, okay? One impressive number that caught my eye as I was doing my research for this is that in 2020, 6.8% of all children under 17 years of age had at some point in their lives symptoms of a concussion or a brain injury. That's a lot of bunkheads, okay? And in 2019, over 16,000 of these kids were hospitalized. And in 2020, when you think about this, 2020, when we were all kind of like locked in our houses, there was still over 2,700 deaths from TBI in this population. So that's kind of impressive. So when you look at these numbers, even though they're not particularly staggering in and of themselves, they're important. So we're going to take a look now at what TBI is, what causes it, what it means, and then we're going to look at an overview of some social determinants of health. So if you don't mind, I'm going to put two buckets out there. I'm going to fill one with some brain injury info and one with some social determinants info. And then we're going to throw them all together and we're going to see where this goes in terms of the management of the population. So what is traumatic brain injury? Here we are on a program sponsored by the Brain Injury Association of Rhode Island, right? So I'm hoping we all kind of know, but if we don't, a traumatic brain injury or a TBI is an injury that actually affects how the brain works. It can be caused by a bump, a blow, or a jolt to the head, or a focal injury like a gunshot wound, all right? The severity is generally divided up into three categories. There's mild, there's moderate, and severe brain injury. And that all depends on the clinical presentation of the child when they first show up at the encounter. A mild TBI, or MTBI, as you'll see it in the literature, is what we commonly refer to as a concussion. And that accounts for almost all of the TBI-related ED visits. Approximately 70 to 90% of them are mild. Depending on the severity of the injury, however, those who have a TBI can face problems that last a few days, a few weeks, or maybe the rest of their lives. So a person with a mild TBI or concussion might have some short-term symptoms like a little dizzy or headaches or a little wonky, a little foggy, and that might clear up in a couple of weeks or a month or so. Kids who have severe TBI, they're more likely to end up being hospitalized or even have a lifetime disability compared to kids who have a mild injury. And these account for a large portion of unintentional injuries that lead to severe disability and death in youth under the age of 18. TBI, and here's why it's important, whether the numbers are big, small, or indifferent, okay? TBI affects children differently than adults, all right? An injury of any severity to a developing brain can disrupt the child's development and limit their ability to participate in school, social activities, sports. And as a result of that injury, children can experience changes in their general health, their thinking ability, and their behaviors that affect their learning ability, their ability to self-regulate, and their social participation. And all of these are important to becoming a productive adult. So these are things that we need to remember as we move forward in this presentation. Social determinants of health. Okay. If I had $1 for every time we've heard this expression since the beginning of the pandemic, I'd be really, really rich, and so would you. All right. Because as the pandemic has progressed, we have all heard this term during the course of the pandemic in the media. And it's good. That's another good news, bad news things. The bad news is we're surviving a pandemic. The good news is we've all become more aware of things that impact the health of our communities. That's a silver lining if ever there was one, right? But these are not new, even though they've really floated to the top of the media popularity scale in the last couple of years. Social structures have been looked at for centuries in terms of their impact on health. And it's not a true story, but certainly you've all heard the story of Oliver Twist, or Les Miserables. They all look to some extent, or have a Florence Nightingale, all look to some extent at the conditions in which people live and how it affects the health of the population. Okay. So the most common current definition of social determinants is that of the World Health Organization. I have it here on the screen for you. Social determinants of health.
Excuse me, Ellen,
Yes.
it hasn't gone beyond learning outcomes on your screen.
We haven't. What happened?
Just wanted to let you know because you were going to a definition.
Oh, my heavens, mercy me.
Thank you.
Can we see it now?
Nope, it's
What has happened here?
on learning outcomes.
I'm going to do this again.
No worries.
I feel like the Verizon commercial. Can you see it? Can you see it now?
Perfect. Thank you.
Great. Do you need me to go back? It's only 2 slides.
That's okay. No worries.
All right. We'll just chug along. All right. Well, that was embarrassing. I'll get over it. I'm good. So anyway, as I was saying, social determinants are those things that are the conditions where people are born, they grow, they live, they work, and they age. It's pretty much the whole lifespan, right? And they're influenced by the distribution. And this is what the part where I almost can hear people's heads explode a little, but we're kind of getting used to the terminology. But they're influenced by the distribution of money, power, and resources at global, national, local levels. All right. So look at a big funnel. You have the whole world, then you have your country, then you have your region, right? The WHO maintains, and I don't mean Tommy and the WHO, the band, I just dated myself, maintains that the social determinants of health are those things that are mostly responsible for unfair differences in the health status or health inequities seen within and between countries. That's a huge statement. These are the things that are mostly responsible for unfair differences. So we're going to do a little touching on that, all right? Just so you'll see what we're talking about. So when we look at social determinants of health, now we know certain things, that these are social and physical conditions. They're not amenable to actual behavior changes on an individual level, because like I said, they're influenced by global, national, and local influences. But we also know that if these things are indeed judged, determined by all of those power structures, if you will, that opportunities on a more granular level can be limited. And they do indeed affect communities. Excuse me, and they do contribute to disparities in health management. All right. Now, I'm going to tell you what that means after this fun fact, okay? I like giving out little statistical things. I call them fun facts, and I'm not trying to belittle it or diminish their meaning, but you hear these things and it's almost mind-blowing. In 2020, a researcher named LaPointe stated in an article, commonly cited statistics show that social determinants of health can impact between, wait for it, 80 to 90% of patient outcomes. Social determinants impact 80 to 90% of patient outcomes. That's amazing to me. And in order to improve the outcomes while lowering costs, which we all know we're beholden to in our value-based society, the healthcare industry, including the federal agencies that pay the bills, Medicare, Medicaid, et cetera, have made an effort to develop programs that can address one or more of these determinants of health. And I'm totally fascinated by that. One example would be like the Healthy People initiatives, 2020, 2030, every 10 years. They address certain social determinants of health. All right. I don't know where all of you live. I live in New York City. An example of how government payer systems can influence social determinants. It has nothing to do with brain injury. During the pandemic, it was obvious that people of color in urban underserved areas of New York City were not getting the care they needed, the vaccines they needed, or the testing they needed. So if you can't, because of inability to get transportation to get there, and all the other things that impacted people's ability to access care, which we're going to talk about. So the city brought it to them, and the trucks showed up outside of the public housing projects with the testing, with the vaccinations, with more testing, and with more vaccinations. And that was like, here, bring the people to the stuff, you bring the stuff to the people. And that's one way that you address social determinants of health and inequities, to try to level the playing field a little bit. Is it the miracle worker? No. Did it help? It certainly did. All right. So when we're looking at social determinants and inequities, what we're really saying is, hey, aren't these the same thing? And I am going to tell you right now, I thought they were too for the longest time. And then as I did more reading and more research, I realized, no, social determinants actually are those things that if you address them, help you achieve health equity. They're two different things. All right. So it's even more it's also defined as when everybody, health equity is when everybody can achieve their fullest health potential, regardless of their social position. And here's the key: other socially determined circumstances. So despite lack of adequate housing, despite all of these things that impact them, we're still able to provide, again, that level playing field so everybody can achieve their optimal health potential, no matter where they land on the social strata. Okay. More formally, health equality is defined as the absence of systemic disparities in health between and within social groups, and that are different levels of underlying social advantages or disadvantages. That is, and here's the big part, different levels on the hierarchy. Okay. So wherever you are on the ladder, doesn't matter. Equity is everybody's okie doke at the same, on the level playing field. So things like poverty, unequal access to care, lack of education, general stigma for chronic illness or disability, racism, religious persecution. These are all underlying contributing factors that contribute to health inequities. A growing body of research shows that there's an important piece of upstream factors that influence health and the need for intervention to identify these factors, in addition to like creating clinical approaches and interventions aimed at modifying the behaviors. Hey, look, I just said another buzzword, upstream. What the heck does that mean, right? Well, upstream is best defined, and the best definition I've seen actually came out of Australia. And it says upstream determinants are those that occur at the macro level, the big level, and include global forces and government policies. Midstream determinants are intermediate factors such as health behaviors, and then downstream determinants occur at the micro level, and that's your own genetics. That's like in you individually. Okay. And that's like one of my favorite definitions of upstream. If you need a visual on that, because I'm a visual thinker, and this is how it was defined for me once, you have a house and then you're downriver, of a big long river, and a bunch of beaver build a dam, and all of a sudden your garden, your farm isn't getting any water because the water is kind of like pooping out and trickling down over nothing outside your property. And what happened there? Because you've had an upstream issue that has now impacted you personally. I hope that visual kind of helps. Now, I have to say that my beaver dam and a farm analogy, I'm very impressed with personally, just saying that, given that I live in New York City and beavers are not a thing. All right. So if we look at inequities now in pediatric brain injury, we're going to look at this like from the almost a reporter's standpoint of who, what, how, why, where. Okay. So who is most impacted in pediatric brain injury? Interestingly enough, the highest rates of TBI-related hospitalization and death in children, actually, and adults, is in the Native American and indigenous peoples. Factors that contribute to this disparity could be high rates of motor vehicle accidents, substance use, perhaps suicide numbers have been cited. And also, here's a big one, difficulties in accessing appropriate health care. In addition to these differences in rates of TBI, other racial and ethnic minorities, particularly non-Hispanic, Black, and Hispanic patients, are less likely to get follow-up care and rehab following a TBI than non-Hispanic white patients. Racial and ethnic minorities are also more likely to have poor psychosocial, functional, employment-related outcomes after having a TBI than their non-Hispanic white peers. And this is not just an urban problem, okay? Rural pediatric TBI patients generally present with higher severity TBIs, and the cost of their stays is quite frequently higher due to the fact that they have longer stays. Sometimes there's a need to transport them to larger institutions with more services to offer, and generally a lack of availability in the area in which they live. So now, okay, so that was a quick fly through that slide, right? Let's go talk about access to care, because everybody talks about access to care as being one of the premium social determinants that impact equity in healthcare delivery. All right, so we all know that not everybody in the United States gets their healthcare services that they need, right? And a lot of this has to do with access. It doesn't just mean being near to or able to get to a provider, although that is a really big part of the problem. But the ability to pay for healthcare is equally important, okay? In order to access care, you have to have some ability to pay. Again, this is not just an urban problem. Considering that the numbers regarding inadequate health insurance, and this is prior to the onset of the pandemic, it was estimated that about 9 or 10% in the United States did not have health insurance. People without insurance were less likely to have a primary care provider, less likely to even seek services, and less likely to be able to adhere to any kind of management that they couldn't afford. So millions of people then, when the pandemic hit, lost their health insurance. And that resulted in actually the highest loss of jobs since the Great Depression. So the number of uninsured is probably, or was probably higher. It's starting to come down as unemployment decreases. Another one of my fun facts, okay, in the US Census Bureau report in 2018, this is a couple of years old, found that the population living outside of metropolitan areas without any kind of insurance was greater than 9%. And it was like 8% or less of the population within a metropolitan area. So your rural population is actually more likely to have access issues in terms of the actual financial issues than your urban people, all right? So now you have your TBI survivors who have lower incomes or are uninsured. They're gonna have significant barriers in accessing care compared with people who have private health insurance or are higher up that socioeconomic ladder that we mentioned. They're like you're going to be less likely to have a procedure. They're going to be less likely to get inpatient rehabilitation. And here's the bad news. They're more likely to die in the hospital because of the lack of ability to go forward. People in rural areas are way more likely to die from a TBI. They have a greater risk of dying compared to people in urban areas. And some reasons for this is just practicalities. They have a little map there, and that's not a mistake. It takes longer to get to an ER when you live in a rural area than you do in an urban area. They probably have less access to a level 1 trauma center, which is the highest level of medical care. Difficulty getting services such as specialized TBI care. Kids living in a rural area are more likely to get a TBI and die as compared to kids living in an urban area. And these children also are more likely to experience delays in getting the care that they need. They might be unnecessarily transferred to another hospital. And then when they're done with all of this, they may not be able to get the post-care services that they need. And we're going to talk about like school and stuff like that in terms of accommodations in school in a little bit. To show you the impact of the lack of services available across the country, and it's really very telling. I love pictures and maps. I'm sorry, folks. If you look at this little map, it shows you the disparities in the availability of just plain old primary care, like your everyday ordinary, the doctor that you're going to go to, okay? In available primary care between urban, metropolitan, and rural areas. The darker the green, the less available is primary care. So look at this. You have the whole, like, way in the deep South, right? And rural, this is New York State, which I am most familiar. You can see it in the rural areas in northern and western New York. Over here, you see, like, in all the Midwestern states over here, going towards the Rockies. The darker the green, the less primary care. Not a coincidence that these appear to be rural areas. So economic stability is one of those factors that impacts, is a significant determinant of health. And we're going to take a look at that and now apply it to our little people with their brain injuries, all right? Economic stability, it always looks at employment, food, housing, and general poverty for the joblessness, people with disabilities, injuries, and chronic illnesses. According to Healthy People 2030, 10% of the population in the United States lives in poverty and can't afford healthy food, healthcare, or housing. Now, we haven't even had a child with a brain injury yet, right? So this is like on a good day. So poverty is not limited to the jobless. There's a lot of people who live with disabilities or injuries or chronic illnesses that might be limited in their ability to work. There are also a whole bunch of people who we call the underemployed, who have steady jobs, sometimes 2 or 3, and don't earn enough to be able to afford the things they need to stay healthy. People in rural and farm communities are more likely to report the cost of healthcare limits their ability to seek care. So when you look at the socioeconomic status and family functioning together, because children obviously, maybe some high school kid works at McDonald's and Burger King and someplace else, or maybe works on the farm, but generally your littles, your children under the age of 10, your little K-8 kids, they aren't working, okay? So it's up to the family environment. You have to look at the family and the child as one unit as a patient. So their family function influences their recovery. So in any family environment, a TBI is an unexpected event. And obviously it causes significant changes in that whole family economic status and structure. Family level factors are critical social environmental influences on the outcome in children after a TBI. Economic and social disadvantages are associated with poor cognitive and academic outcomes following a severe TBI. Regardless of the injury severity, which makes everybody worried, which creates worry and concern about the kids' futures, especially as they approach adulthood, parent caregiver burden and family dysfunction are also an important consideration because they are a strong determinant of a child's recovery, with children from well-functioning families demonstrating better psychosocial outcomes than those without. Survivors of a moderate or severe TBI, let's keep in mind these are the children who are going to need rehab and a lot of post-acute care intervention. Their issues can last for years following an injury. Survivors of this level of TBI face a really rough road to recovery that requires physical therapy and behavioral health treatment for months or years in duration in order for them to return to their pre-injury function. So we're talking about months or years in terms of a child. Months, I don't know. I remember when I was a little kid, if I was 6 years old and there was somebody who was 8 years old, they were too old for me, right? So 2 years is it's like dog years, like forever. So you have a child now who's going to says an injury when they're 8. And if their injury and their ramifications of the injury lasted for years and they get into high school, now what? Now we've got these children with social and cognitive and academic challenges that they've had for years. Excuse me. So now we're going to talk about moving into the community, social and community context. We know that nothing happens in a vacuum, right? So we have to look at the relationship of the social and the community context to the social determinants. As we move from these concepts, I know they kind of sound a little bit different and a little divergent, but I want you to think about them as ingredients of a cake, all right? Each one of these concepts can stand alone, and we can talk about it all day, but together they influence the greater whole, or in this particular analogy, bake a cake. Every single one of these social determinants is an ingredient into a giant cake. And that cake is topped off and has a side dish of health inequity. All right. So people's interactions with their family, their friends, co-workers, other students, and community members can be referred to as their civic participation. These relationships greatly influence the health and well-being of any individual. And social supports are really important because they provide a positive influence. When you live in an area where there's discrimination, unsafe neighborhoods, difficulty in affording the necessaries of life, these all have the potential to negatively impact health and safety across the lifespan. If there are positive relationships at home, work, school, and the community, these negative impacts can be reduced. But there are many people who do not have that level of support. Family environmental characteristics such as overall family functioning. Remember the family members who have to work 3 jobs to put food on the table. Parenting practices. Oh yeah, remember the parent who has to work 3 jobs to put food on the table and therefore is not really home a lot to parent, right? May affect the child's educational performance and their social abilities and their behavioral outcomes post-TBI. Children live within the context of the family. And so the parenting skills, not only the parenting skills and practices, but also their own medical follow-up is important to this, and the communication with schools. And all of these in turn impact the manage their ability to return to pre-injury function. So now you have your social context. We're getting bigger now. We're going to the neighborhood and the built environment and things that impact health. All right. So the neighborhood in which that social and community context takes place, it has a very big impact on the health and well-being of the individuals who live there. And again, the description I'm going to give you is I'm going to say on a good day. This is before someone in your family has a brain injury. So the neighborhoods that people live in have an impact on their health. Many people live in areas at high rates of violence, unsafe air and water, and other health and safety risks. Racial and ethnic minorities and people with low incomes are more likely to live in places with these risks. In addition, some people are exposed to things at work that they end up bringing home will impact their health, which impacts the health of their family unit, like secondhand smoke, fertilizers, loud noises, drilling, working in a subway system, working with heavy equipment on a farm, dealing with the fertilizers. There's a million things that could be impacting the neighborhood and built environment which people work and live. And in generally, these can impact then the family supports, right? And then, the little ones send roll over. So if dad gets sick because of all of this stuff and he can't provide, and you have Joey with the TBI and mom's working 3 jobs to put food on the table, I think we have a bit of a challenge here. And this is where the inequities start to pile up. All right. Other factors that impact the social health and the inequities of healthcare are those in the environment. Where you live geographically, I've said it before, rural and urban. Rural, well water can be contaminated and cause all kinds of problems, right? Urban, noise pollution, don't I know it? It's like I've grown up in New York City my whole life. And when I go away to the country, I have to turn the radio on because I cannot sleep if it's quiet. Again, race and ethnicity. We have known for a fact that racial and ethnic minorities encounter more environmental hazards than non-minorities. Again, a national study of a U.S. Census tract data found that Hispanic individuals and non-Hispanic Black individuals are more exposed than non-Hispanic white individuals to airborne particulate matter, such as, and here's a list, chlorine, aluminum, elemental carbon. And obviously this exposure is associated with bad health outcomes. Economically disadvantaged communities are disproportionately affected by environmental conditions. All right. The classic example is when you have a large housing development that's low income housing, and there's a large presence of maybe cockroaches and vermin and mouse droppings and whatever. The higher the ratio of that, the higher the incidence of asthma. This is well documented in the literature. You're not going to see that level in single family homes. Single family homes report low levels of mold. You're not going to find that in public housing. You're going to find higher levels of mold. And like, as I said before, remember that these are things that happen on a good day before your child has had a brain injury. Education, you know, we all work our day jobs. Some of us go to school and work our day jobs, but children have a job, education, go to school. That's their job. You have one job, go to school, right? So we know that in terms of education and social determinants, that people with higher levels of education are more likely to be healthier and have a longer life. Access to higher educational opportunities for children and teens, as well as helps them do well in school, is key. Some children live in areas with poorly performing schools. So a lot of families can't afford higher education for their children. Living in poverty can affect a child's brain development and make it even more difficult to do well in school. So it stands to reason that children from low-income families with disabilities or those who routinely have social discrimination issues such as bullying are going to struggle with things like math and reading. They're going to be less likely to graduate from high school or go to college or a trade school. They're going to be less able to get good, safe, well-paying jobs. They're going to have chronic health problems. And if you just insert the words total brain injury, where you already have an issue where there are going to be cognitive and thought processing difficulties because of the injury itself, you now have the double whammy. Lay it on that they're at risk for other chronic health issues such as heart disease or diabetes. Now we're getting down to the nitty gritty of the brain injury issues with children and the social determinants. Cognitive, behavioral, and social effects. All right. After a brain injury, cognitive problems affect not only learning, but how children interact with their environment, with their world. Okay. A lot of these effects include attention span, memory, processing speed, and executive functions. I love that term, such as the ability to quickly switch thinking from one topic to another, which is very necessary in a school environment, right? Being able to self-monitor, self-regulate, not act out, planning, organizing, decision-making. So when you complicate that, okay, with living in an urban area with a not so high performing school, with the inability to be able to do your work from home on a good basis, you know, that's going to be a real big impact on your ability to recover from a brain injury, from the child's ability to recover from a brain injury. There are skills that impact a kid's academic success, like that lead to inconsistency in learning. There are impacts and gaps of knowledge. Let's face it, if somebody has a head injury, let's say a moderate to severe head injury, they're going to be out of school for a long time. There's going to be an awful big knowledge gap there that has to be overcome, which is going to directly impact their ability to graduate or pursue any further education. So you can see that there's like a spiral. I'm in this situation where these things impact me again on a good day. Now I have a brain injury and it's impacting it even worse. And they're never going to go back. So, okay, we're back to the beginning now because you never get out of it. It's like the habit trail. You have a spiral of a habit trail with the little hamster running in the wheel. That's the kind of thing it is. It just keeps going and going and going and you can't get out. A few slides back, I mentioned the impact of community and social context in terms of inequity. You throw in a brain injury, right? And this child is now going to manifest behavioral issues such as, okay, disruptive behavior, poor conduct, emotional distress, lack of empathy or moral reasoning, those executive functions. These are children who are going to have trouble with peer relationships and may not have many friends. All right. These are the children who are going to be more prone to bullying. So now we've actually added a layer onto already existing problem. Again, we're back on that habit trail again. And remember what I said too about people experience social discrimination. They're going to struggle more with math and reading. So they're going to struggle more because we already know that children who live with social determinants and health inequity situations struggle with these things. And, this is obviously a layer, putting another layer on the big old cake that we were baking with social determinants, right? And of course, we can't forget our parents and our caregivers. They are indeed the other clients in this situation. So when we're looking at parental coping, remember, they're looking at a unique set of stressors because they themselves are not the person experiencing the clinical issue. They have to adjust to the emerging behavioral difficulties and have concerns over the long-term functioning of this child and the implications on that child's future independence. TBI and recovery following the injury are in themselves significant stressors for families. They result in increased caregiver burden, the psychological distress even years after. More than a third of parents and children with TBI report clinically elevated levels of anxiety and depression. And some researchers have identified that there's a reciprocal relationship between levels of distress and the child's behaviors, further reflecting the importance of being able to address parent and family outcomes as well as the child's outcomes post-TBI. So again, just throwing this out there. If mom's working 3 jobs and dad just lost his job because of his own illness and Joey's home after having had a moderate TBI, can you imagine the level of stress that family is experiencing because of the health inequities imposed on them because of the social determinants of their health status? And actually almost breaks my heart. Anyway, let's move on. Here's a fun little research for you. Parents of children who sustained a TBI in preschool report generally greater stress during the initial 18 months post-injury. And level of parental distress are higher for parents of children injured later in childhood than those injured in preschool years. Increasing demands for self-regulation and executive function during the middle school and high school years contribute to emerging deficits and concomitant parental distress as the child ages. With kids injured at younger ages actually prone to these adverse effects. Remember I said earlier that as the brain is developing, children with their brains developing are at a higher risk of complications further down the line. So if you have a little toddler who has a brain injury, you might think it's not quite so stressful. It kind of makes sense in a way because toddlers don't do much anyway. They toddle, right? But as a middle schooler and a teenager who, and I've loved saying on a good day, as we all know, and I'm being a little bit flipped, but I know from my friends' experiences, raising a middle school child and a teenager is getting real, right? It's not easy on a good day. So if you have a child who now has executive function difficulties and behavioral difficulties and cognitive impairment at those ages, that's way more difficult to deal with. But some of that stuff may have actually started with an earlier injury years prior. So we have to be able to be responsive to the needs of the parents and the caregivers to find out where are they in this timeline, how has it been, where are they now, what do they have to look forward to in the future in terms of their ability to cope with the stressors of their child's future improvement. And that leads us, when you ask these questions and find these things out, this brings us to the concept of coping style. There are 2 categories of coping style. There's emotion-focused and problem-focused. And these are aimed at looking at the emotional distress caused by stressors and such as injury or, in this case, a TBI. The way you deal with these two categories is actually how you actually address the problems themselves. All right, let's use an example. All right, because you can be avoiding things, coping and disengagement, and those are consistently linked with negative outcomes and increased distress. Problem-focused coping is beneficial in situations that can be changed. All right. An example of problem-focused coping is someone breaks their leg, they go to the ED, they get a cast, they stay home, people sign the cast, they get walk with crutches, they get an elevator key at school, aren't they special? And then they get their cast off. That's problem-focused, okay? Coping. Boom, boom, boom. We have to do this, we have to do this, we have to do this, we have to do that. Emotion-focused, all right? Let's talk about like the neurological complications associated with TBI. These are unlikely to improve despite the parents' efforts to change the situation, okay? And they may be more successful in reducing caregiver distress than active coping directed at changing the consequence. So you have to work on ways to reduce stress instead of solving the problem, because a lot of the issues of TBI are not concrete. You can see a fracture, you can see the cast, you can take that cast off, right? You can put the crutches away. With the TBI, it's all very not visible. So it's very emotion driven in terms of coping. When we look at medical management on the acute side of a TBI, location matters. Children treated at pediatric trauma centers have a significantly better outcome than those treated at adult trauma centers. 35% of these children treated for TBI are not even seen at a trauma center on initial presentation. These children are likely to receive less than optimal, based on the Brain Trauma Foundation guidelines, care immediately after injury. Keeping in mind the earlier discussed differences about the availability to access these services in all areas, particularly in rural communities, and you can certainly identify that this is a major inequity in this population. Further, children are twice as likely to be taken to an ED via private transport than by EMS, which results in the loss of benefits of the EMS field intervention and the early application of field triage guidelines. Oh my goodness, Joey fell and hit his head, he's bleeding, and you throw him in the car, a cab, or whatever, and you get to the ED. We're not waiting for 911, we're not calling EMS. And if you live in a rural area, again, how long is it going to take that ambulance service to get to you? So that makes a lot of sense when you think about where that falls out in terms of equity. Remember what I said before, that 70 to 90% of children who go to the ED have a mild TBI. And they're sent home usually right after treatment in the ED. Some studies show that the rate of follow-up in the year after a TBI shows a lack of coordinated follow-up. There's a lack of consistency in communication and medical information between the healthcare setting and other providers, and most significantly in this group, educational settings. So it's important that when we talk about educational settings, that these things be communicated to perhaps the school nurse. In the absence of having other alternatives to treatment, you might be able to follow up with the school to have the nurse keep an eye on things, right? So now let's move into, okay, this is all wonderful. What do we do about it? Okay, case managers, it's time for us to get to work. If we use the case management process, remember that we have two clients here that are wrapped up into one client. You have the caregivers, the parents, the guardian, whomever, and the child, and they are one unit. All right. You need to be able to have a discussion about outcomes. What are your expectations for what's going to happen here? How best can we help you achieve those outcomes? We have to remember that follow-up is key, given what I just said, that a lot of these children have no follow-up after that initial ED visit. And then stuff happens a year down the road and everybody's like, what happened? All right. And advocacy. Again, if I had $1 for every time I said this word as a case manager, I'd be really rich. It is our number one purpose as case managers is to advocate for our clients, because we are the ones with the resources. We are the one with the knowledge base, and we are the ones who are able to help that family, that child, move through the healthcare continuum, if you will, to achieve the best outcomes possible. You know, that is our role, is to advocate for that child. So when we talk about the case management process, we're obviously talking about if you're a nurse by profession and not necessarily a case manager, you're going to recognize this because it's the nursing process as well. Assessment, including screening and risk management, planning, intervention, and evaluation. This is a huge high-level overview of the case management process. If you're not familiar with it, don't get crazy because it's a lot of blue things and red things. But what I want you to notice mostly is it's not really a straight line. You have arrows going one way, and then they zoom back, and then they can go forward again like a swing. I like to look at this. I call it the case management cha-cha, because you go a little bit forward, and you go a little bit back, and you go a little bit forward, and you come back, and then finally you go cha-cha-cha, and you move forward. All right? So this is one way to look at that. When you look at a child, the earlier, though, I want you to look at this, the far left-hand side of the screen, you'll see it says screening, stratifying, risk assessing. That's really all one piece of the puzzle. But the key point here is that the earlier the case manager gets involved in the case, the better the outcomes. Okay? Not that it's all about us, but it is all on us. Okay? No, I'm kidding. But it is important that at the clinical point of contact, that the case manager establish a relationship with that family, identify the risks that the child faces, and ultimately facilitates communication between and among providers and make any necessary referrals. Advocacy. I'm going to talk fast. Really, if you think I talked fast before, just wait. When you look at risk, there's a lot of variability in how a kid's medical history, school performance, and family circumstances are considered in the initial encounter. All right. It's important that these be part of the process. How is he doing in school before? Because you have to have a baseline. You have to know where we're going. When you're looking at the child's, the client's level of knowledge, there's a lot of points to assess. Does the client understand what you're saying? Because they say yes or shake their heads doesn't necessarily mean they really understand. Make sure they know what you're talking about by using a bit of a teach back method. You know, hey, could you tell me what I just explained to me in your words, what I just explained to you? When you speak with the clients, don't use medical terminology when you're doing the risk assessment, because they're just going to go, okay. Anything you give them in writing should be like at a 5th grade reading level or below. Don't assume they understand. I'm going to say that over and over again. Always ask them every step of the process. You know, ask if they understand why you're asking the questions you're asking. And then you're going to be able to facilitate a plan going forward. The biggest important thing is, and remember mama with the 3 jobs, okay? Ask if they're able to participate in the child's care. I know as an adult case manager, it was always easy to go, oh, you live with your daughter? Okay. And you walk away. Right? But you forget to ask, does your daughter have a day job? Is your daughter home at night? And then you find out that the daughter not only has a day job, but she goes to graduate school 4 nights a week. And the other 3 nights, she's like, you know, doing schoolwork or maybe picking up an extra shift somewhere. All right. So that is not a viable caregiver. So you have to make sure you dig deep to make sure you know where you're at. Because if mommy's working 3 jobs, you're going to have a conversation about that. Acuity is exactly what is the extent of the illness and the injury. The injury. What do they understand about it and how complex it can be? All right. So what kind of care are they going to need moving forward? It's a real look at how bad is it? What do we need to do to make it better? And who do we need to put in place? What is the team that needs to be put in place to make that happen? What are the resources? What kind of education has to take place? Planning. Okay. Nothing happens without a plan, right? I mean, I'm the great Excel spreadsheet writer. I write lists of lists. Okay. Obviously, it has to be individualized to each client. We have to be able to consider when we're doing the planning, what level of participation will the family be able to provide? And family is, generic for who the caregivers are. Again, what is their understanding? This is not a one-off. This is going to last a while. What kind of support systems are available? What kind of follow-up are we going to be able to make? Who is on the team? What physicians, what providers, what family members, what caregivers are going to be able to work with this family? What is their current level of functioning, their socioeconomic status, and their ability to access transitional services? Even littles with a mild head injury can benefit from post-discharge accommodation. I had told you before, I'd mentioned it now. When that child leaves, they might be able to go back to school in a couple of days, but they might be dizzy, they might be vague, they might fall asleep at their desk for a week or two or a month post-concussion. The school needs to be aware of that, needs to be involved in that, so that the school nurse and the appropriate people can be available to do an assessment and make sure that any accommodation that the child needs, they might need a temporary helper. They're called IEPs here. I don't know about other places. But, an assistive person to help them through this post-acute period. Might not be permanent, but they might need a para or somebody to sit with them in school to keep them awake and keep them focused. That goes to the moderate and severe if they return to school as well. Just like in a workers' comp situation, we worry about accommodation. We need to be able to accommodate the needs of children in school. When we implement the plan, make sure that the return to school process, make sure we have a return to school program, okay, that there's one available. We need to be able to optimize the availability of the post-acute level care, rehab services if and when available, and other community services. We have to be able to know our resources, know who you can call, what resources are available for children in your area. You can look through your local county or city or state or other networks such as your local brain injury association, wink, and be able to ensure that the family can provide for the services needed. Provide educational materials that people can understand so they know what they need to do as they address things going forward. And last, post-transition, make sure that they are comfortable with the plan, otherwise it's going to fail. Ensure that there'll be some level of periodic follow-up. Call, give them a phone call after discharge, or make sure that there's somebody in place post-discharge who will follow up with that person. It could be a medical health home. It could be a nurse in the community center. It could be the nurse at school. And this helps alleviate anxiety and apprehension on the part of the child and the family. So in conclusion, as I squeak it in at the last second, when you're looking at the health inequities in TBI, it's up to us to be able to understand the factors that influence the long-term effect on the needs of children with all levels of TBI severity. We have to be the ones to recognize the barriers to recover in their environment, because they might think it's okie dokie to be living with 10 people in a 3-room apartment. We have to recognize that this is going to be an impediment to care. Family resources and education. What do they bring to the table? What does the school bring to the table? And then what can we bring to the table by facilitating the communication between and among all of the providers? There was a lot to tell you in 1 hour, and I cut that back. But are there any questions before we call it a day?
Well, I'm going to look through the, thank you very much. It's very thought-provoking and interesting, and something that's near and dear to our hearts here at the Brain Injury Association of Rhode Island. Some of the questions that I had in here was, along with the school nurse, wouldn't you also want to work with the school social worker or the psychologist? Would a 504 be helpful as well? I'll let you speak to it, and I can talk about the REAP on our side because we have some guidance as well.
Actually, absolutely. When I talk about the school nurse, it's like I have this vision of the nurse with the white clinic shoes and the white and everything. But yes, if your school has those resources available, counselor, social worker, behavioral health technician, para professionals who can sit with the child, nurses, go for it. The more the merrier. And that was why I said at the end to get together, facilitate communication between all of the providers and the caregivers and everybody who will be involved in the child's care. Good call.
Right. And we also have in Rhode Island, we have like the Rhode Island REAP manual. So if people do visit our YouTube channel, which this recording will be on, and we also have other recordings. The REAP manual is a community-based concussion management program. So that has a different, they separate it into colors. So one would be for the school nurse or the medical, one would be for the outside medical, one would be for maybe sports and physical, and one would be academic. We just need to make sure that we get that information out to teachers in our state. People can call me. I don't want to take up a lot of time, but you can definitely call me and I can work with any school there, because there is a little bit of a difference between returning to school and returning to learn. They might be able to go back to school because you want to get kids back in school as soon as possible, but the deficits that they have might be ongoing, like you had mentioned earlier.
And this is another reference too. In 2018, there was a report to Congress. And if you can Google it, report to Congress, pediatric brain injury, it'll pop right up. And it has a whole section on return to school, return to social, return to sports in there as well. Very helpful resource.
Yes, we have the protocol set for the state. It's just getting the information, which was another question about how advice on getting brain injury information to the parents and the schools, because we have the information. It's been a little bit challenging during COVID for obvious reasons, but how do we really break through to make sure that a parent that has a child with a brain injury gets the information as soon as possible, and we can interface with that and help them navigate, whether it's the medical or the educational would be in my case. I can interface with the schools.
Right.
The 504 plan, I know that someone mentioned, it's usually not used as quickly. You got the MTSS and the RTI, and you make accommodations. But if it's something, it depends on the severity, because if it's a concussion, it's usually going to be temporary. They probably wouldn't go to more of the IEPs, the 504 plans, unless it was long-term, in my experience. Any other questions that people have? Look right here. Practicing wait time, right? I'll mention another thing that I thought was really interesting. They find that on average in the country, that 40% of kids in juvenile justice system had a TBI or reported something that would be considered a TBI, and that translates to 60+% at the adult level. So that's a whole other area where we talk about where maybe if there's intervention earlier, that wouldn't, progress to adult incarceration.
Which is actually very interesting, because when you look at the data for social determinants of health, that you look at that there is indeed a high propensity for criminal activity and incarceration in populations where there's a huge impact of social determinants.
Definitely. Anyone else for one last question we can put in? Okay, well, thank you so much. I want to remind people to fill out their evaluation for their CEUs and mail that to richard@biari.org. We certainly appreciate your time and your efforts here. This will also be recorded and put on our YouTube channel probably by the end of next week is a realistic expectation. And you can just go onto YouTube and you have to type out Brain Injury Association of Rhode Island. And there are quite a few recordings that we have there. Well, this concludes today's session of Play Fair, the Impact of Health Inequities on Children with Traumatic Brain Injury. We thank you for your participation. We thank you for giving us the lovely webinar. And the rest of our conference series you can find on our website, biari.org. Have a great rest of your day.
Thank you, Doreen. Thank you, everybody. Have a great day.
Take care.
Bye.
Appreciate it.